Welcome back to our channel, friends. Today we will see 8 important steps to solve any ABG that is given to you. Okay, just follow these steps systematically one by one so that any ABG given to you, you will solve it easily. Okay, let's start. First, whenever you see a ABG, 3 values you should remember by heart. First is pH. Normal pH is 7.35 to 7.45. Single value 7.4. Next, PCO2, carbon dioxide, 35 to 40. Single value 40. Next, bicarb, 22 to 26 milliequivalents per liter. Single value 24. So pH 7.4, PCO2 40, bicarb 24. Step number 1. First, identify the acid-base abnormality, whether it's acidosis or alkalosis. How to check? So the basic equation is pH is directly proportional to bicarb and inversely proportional to PCO2. Bicarb is the alkali, so if it increases, alkalosis; if it decreases, acidosis. And PCO2, carbon dioxide, forms carbonic acid. So remember it as acid. If it increases, it is acidosis. If it decreases, it is alkalosis. So check the pH alone. If it is more than 7.45, it is alkalosis. If it is less than 7.35, it is acidosis. Yeah. So carbon dioxide, PCO2, it forms carbonic acid in the body. It is puffed out, as we know, by the lungs. So if any respiratory pathology is going on which blocks the puffing out of carbon dioxide outside the body, then carbon dioxide accumulates, carbonic acid accumulates, so it's an acidosis due to respiratory pathology, so respiratory acidosis. Or if due to some respiratory pathology, if more puffing out happens of carbon dioxide outside the body, then carbon dioxide PCO2 levels fall low, alkalosis due to respiratory pathology. It is respiratory alkalosis. So instantly after seeing pH, look for the PCO2 values. If it is acidosis and if PCO2 value is more than 40, then it's respiratory acidosis. If pH shows alkalosis and if PCO2 values are less than 40, then it's respiratory alkalosis. Yeah, then it is bicarbonate. It is excreted out or reabsorbed by the kidney. So it depends on the metabolism in our body. Metabolic acidosis. Acidosis meaning pH should be less than 7.35 and metabolic meaning bicarb should be less than 24. Next is metabolic alkalosis. pH greater than 7.45, metabolic bicarb more than 24. Next step is matching. First see the pH. If it is less than 7.35, it is acidosis. Match what parameter matches with acidosis. See the bicarb and PCO2. If bicarb is less than 24, it is metabolic acidosis. It's your primary disorder. If PCO2 is more than 40, then it is respiratory acidosis, which is the primary disorder. Same, if pH is more than 7.45, it is alkalosis. Match what is matching with alkalosis. See bicarb. If it is more than 24, it is metabolic alkalosis. Or if PCO2 is less than 40, then it's respiratory alkalosis, which is the primary disorder. This step determines the primary disorder given to you. Next step is look for compensation. Like if any metabolic disorder is going on, then the compensation will be respiratory. Or if respiratory pathology is going on, compensation will be metabolic. See, first let's take metabolic acidosis. Here bicarb is low. Acid is accumulating. Acid needs to be puffed out of the body. which is the carbon dioxide or carbonic acid, is puffed out. So PCO2 should fall as a compensation. The expected PCO2 is equal to 1.5 times the bicarb plus 8 plus or minus 2. You will get a range of PCO2. This expected PCO2 should lie within this range. Next is metabolic alkalosis. For this, alkali is accumulating. So what should happen? Acid should also accumulate to neutralize it. What is acid? Carbon dioxide. So lower the respiratory rate, keep the carbon dioxide within your body, keep the acid within your body to neutralize the excess base. So compensation will be, if bicarb increases, PCO2 also increases to compensate. The expected PCO2 will be bicarb plus 15. Next is respiratory acidosis, where PCO2 accumulates, acid accumulates. So as a compensation, alkali should also accumulate to neutralize it. In case of respiratory acidosis, there are acute as well as chronic states. If it's acute, sudden onset, kidney won't be able to reabsorb bicarb that fast. So for every 10 millimeter increase in PCO2, there will be only 1 milliequivalent increase in bicarb. Whereas in chronic states, for every 10 millimeter increase in PCO2, there will be 4 units increase in bicarb. Next is respiratory alkalosis. Here, same, acute as well as chronic states. In acute state, for every 10 millimeter mercury PCO2 decrease, there will be 2 units decrease of bicarb. In chronic states, same 4. For every 10 fall in PCO2, there will be 4 units fall in bicarb. So you can remember, like any chronic respiratory problem, compensation of bicarb will be 4. And in acute states, respiratory acidosis, it will be 1, and respiratory alkalosis 2. Thus, we saw the formulas of compensation of all the primary acid-base disorder. This we call it as secondary compensation. 3 steps over. Next is analyze the compensation. Whether it is fully compensated, that's it, your problem ends here, tata bye bye. Or if it is partially compensated or it's not at all compensated, then that means it is a mixed acid-based disorder going on. Meaning some more pathology is preventing the compensation to happen, which we'll be seeing detailed here. Next is the most important step, anion gap calculation. Never say an ABG as normal without calculating this anion gap. Because what is this anion gap? In our body, number of cations is always equal to number of anions. Then where is that gap? The measurable cations, if you see, sodium is the predominant cation. In anions, if you see, the measurable anions, chlorine and bicarb we measure. But there are lots of unmeasurable anions present, which are like sulfates, phosphates, all those. So this constitutes the gap, the anion gap. How to calculate this? Take sodium value, from that subtract chloride and bicarb value, you will get this gap, which is the anion gap, which is indicated as black in that diagram. So normal will be 8 to 12, single value 12. So what happens when some alcohol is taken into your body? All the alcohols will be oxidized into acids like ethanol, methanol, glycols, all these oxidized to respective acids. These acids, like acetic acid, if it is formed, it will be splitting into H plus, a proton, and anion like acetates. This proton will go and neutralize the bicarbonate pool. So there is a gap created in the anions. This gap will be filled by the extra anions like acetates. So if you see, the anion gap will be increased. So any extra acid added to the body will increase the anion gap. This is high anion gap metabolic acidosis. Let's see the causes of HAGMA, high anion gap metabolic acidosis. Okay, remember this animal, cat sitting on the mud and it is piling up. Cat mud piles. C. Carbon monoxide or cyanide poisoning. A. Aminoglycosides toxicity. T. Toluene. In the question they give like glue sniffing. M. Methanol toxicity. U. Uremia, which is seen in CKD patients, kidney disease patients. D. Diabetic ketoacidosis. Ketoacidosis can also be seen in alcoholic as well as diabetics and starvation ketoacidosis. Next, piles. P for pills like iron or INH, antitubercular drug. L for lactic acidosis. E for ethanol, ethylene glycol toxicity. S for salicylates toxicity. So if we briefly see the cause of HAGMA, majority of them will be a drug or a toxin. Exclusions are, one is ketoacidosis. So check for urine ketones, blood ketones in this patient if HAGMA is found. Next, check for kidney function tests because CKD can be a possibility. So ask for history and clinical features also of CKD. Next, if it is due to lactic acidosis, it can be short bowel syndrome causing D-lactic acidosis. Any history of GI surgery. And if it is L-lactic acidosis can be seen in congestive cardiac failure patients as well as mitochondrial disorders. So if it is cardiac failure, see for the clinical features and history of MI or coronary heart disease, all those things can ask. Then all the remaining causes will be drugs or toxins. So run a toxic screen in such patients. Metabolic acidosis with normal anion gap. Causes if you see very easy, RAD, R-A-D. R for renal tubular acidosis, A for Addison's disease, D for diarrhea and also GIT causes like any diversions. In case of bladder cancer, what they will do is they will re-implant the ureter into the GIT. That will cause acidosis. Next is pancreatic fistulas. So why NAGMA or normal anion gap metabolic acidosis is caused in these situations? First, if you see RTA, renal tubular acidosis, in one type there will be bicarbonate which will be lost excessively in urine, and in one type protons can't be secreted into urine, protons will accumulate in the body. And in Addison's disease, the aldosterone levels will be very low. Aldosterone is important for proton excretion outside the body, but since it's low, protons accumulate. And in these diarrhea and all these diversion procedures, lot of bicarb is excreted in stools, lost from the body. So what happens? See, in these causes, bicarbonate is lost by one or the other way. So if bicarb is lost, chloride, the other measurable ion, will compensate and will maintain the anion gap exactly the normal. So this is NAGMA or normal anion gap metabolic acidosis. Yeah. Next, is there any way by which I can find out the cause easily? Yes. After finding out NAGMA, you should go and calculate urine anion gap. Urine anion gap is formula is different for it. Urinary sodium plus urinary potassium minus urinary chloride. If you calculate this urinary anion gap, if it is negative, then it's a gut cause. Remember, like negative, gut causes like diarrhea, diversions or pancreatic fistulas. If it is positive, then think of other two causes, renal tubular acidosis or Addison's disease. Next is the last and important step, which is the calculation of delta ratio. What is this? See, in HAGMA, what happened? The extra acids added made a fall in bicarb, there was a gap created which was filled by the extra anions, leading to increased anion gap. So in short, if you see, the change in anion gap will be equal to the gap change in bicarb. This is delta ratio of change in anion gap by change in bicarb. Change from 12, how much it is changed, like the given by anion gap minus 12 by 24 minus the given bicarb. If you calculate, since the change will be equal in both directions, the ratio will be between 1 to 2. Okay, if it is between 1 to 2, we can surely say only HAGMA is happening. If delta ratio is between 1 to 2, it is only HAGMA. If it is less than 1, then it means HAGMA as well as NAGMA is coexisting. And if it is more than 2, then it is HAGMA plus metabolic alkalosis. How are all these things? Let's see it with two different examples. First, let's take an example of a patient with alcoholic ketoacidosis with severe vomiting. So as we know, in alcoholic ketoacidosis, what happens? The extra keto acids will form protons, and these protons will reduce the bicarb level. And the gap will be filled by the extra ketates like acetates, all those things, and anion gap will be increased. But the patient also has severe vomiting. So what will happen? In vomiting, HCl is excessively lost from the body. So protons are lost, meaning bicarb is gained. Bicarb increases there. So now if you see, the patient's bicarb is actually higher than expected. Now tell me the change in bicarb. 24 minus the bicarb is increased now. This value will be falling now. When denominator is falling, the delta ratio will increase like anything. So it will increase more than 2. Then that means HAGMA due to alcoholic ketoacidosis and metabolic alkalosis due to vomiting are coexisting in this patient. It can be found out only when you apply this delta ratio. Then next example, same alcoholic ketoacidosis patient is having multiple episodes of diarrhea. What happens here? Same alcoholic ketoacidosis will increase the anion gap and will cause fall in bicarb. But he is also having diarrhea, meaning still further bicarb is lost from his body. So bicarb is very minimal here. So what will happen to the change in bicarb? 24 minus very low bicarb. That value will be increased. So when denominator increases, delta ratio falls less than 1. That means HAGMA due to alcoholic ketoacidosis and NAGMA due to diarrhea is coexisting in this patient. Can be found out only when you calculate delta ratio. Hope you understood. So the 8 cardinal steps are: first, pH acidosis or alkalosis. Next, primary disorder. It's respiratory or metabolic. Next, compensation. It's next, analysis of your compensation, whether it's completely compensated or partially or uncompensated. Next, anion gap calculation. Sixth is, if HAGMA, what is the cause of HAGMA going on? Seventh is, if it is NAGMA, what is the cause of NAGMA going on? Eighth is last delta ratio calculation. In exams like INICET, they will give questions which will make you go till the last step. Yeah, that's it. We'll be giving lots of ABG questions in our WhatsApp and Telegram groups, and the notes for the same video will be uploaded in our WhatsApp and Telegram groups. Make a good note of all these steps in your notebooks and start practicing ABG questions, because in NEET minimum 4 to 5 questions are possible in ABG, and INICET they will definitely ask in ABG. And also in practical situations, ABG plays a vital role in diagnosing many disorders. So it's vital that you have a master of all these concepts by listening to complete discussion. We'll see you in a new different ABG problem solving video in our next sessions.